Good afternoon. Thank you for joining today on Wonderful Wednesday for the third part of unstable tachycardia when your tachycardia is wide. So it's okay if you haven't been to the previous two. It's really okay. No one's taken attendance. There's no requirements. And I'm just so happy that you're here with us today. And this will also be available on my YouTube channel, which you can subscribe to or just visit. There's about 70 videos on my YouTube channel that you can peruse at your leisure. Thank you again for joining today. So, want to make sure that we appreciate when tachycardias are wide. One of the first things that we're going to think about is there a possibility that I have a supraventricular tachycardia that is aberrantly conducted? And the aberrantly conducted beats are typically conducted through a bundle branch block. So there are two leads that we're going to choose on a 12-lead EKG. Those leads, one will represent the right heart, that will be V1. And on our 12-lead EKG, the lead that represents the left heart will be V6. Now, doing V1 and V6 are really meaningful when I have a 12-lead EKG to try to differentiate VTach from bundle branch block wide QRS tachycardia. And just remember, sometimes you don't have time to make a diagnosis. If the patient's unstable, you're going to treat first and evaluate later. But if you have time, the patient has a pulse, maybe he doesn't feel that well, but he's not really profoundly hypotensive. You have some time. It's good to try to make a good diagnosis. So you're going to choose the V1 lead, that is the fourth intercostal space, the patient's right side of the sternum, and V6, which will be the fifth intercostal space, the mid-axillary line on the left side. Now, on a bedside monitor, what you're going to do is take your little red electrode for your left leg, bring that up to the fifth intercostal space, mid-axillary, and that's going to give you a modified V6. So you'll have a true V1, you'll choose lead 2, but in your mind, you'll know that it's a modified V6. And these are really simple strategies. Really simply, we should remember that current always goes to the left heart. So V1, which is a right-sided lead, should show that current goes away from V1, and that visual should be primarily down. And V6, which is the left-sided lead, should show the current coming towards it, and that visual should be primarily up. So that means your ventricular depolarization V1 will primarily be in a downward direction below the baseline, and V6 will be primarily in an upwards direction above the baseline. Now, you always need to check this V1 and V6 or V1 and modified V6. And remember that normal direction of current in the heart is always to the left. So in V6, it should be upright, and it should always be downwards in V1. So first and foremost, we look first at direction. Okay, if the current is primarily towards V1, which means current is going to the right, that is the wrong direction. So if the current is going primarily to the right in your V1 lead, it will be primarily upright. This will indicate to you the possibility that it's a right bundle branch block, current to the right, and terminally the current not going to the left. Now, you'll still have an upright in V6, but then after your R wave, you'll have a wide, deep downwards that we call an S wave. S wave is not normal in V6. So when you have an S wave in V6, that means a downward deflection after the R wave. When you have an S wave in V6, always look to V1 and see if it's primarily upright. Now, that's really important. First, you're going to look at direction. Is direction normally to the left, or is your direction abnormally to the right? And after that, you're always going to look at how much time it takes. So remember, ventricular depolarization totally should occur in less than 0.11 seconds. So if the time it takes from the beginning to the end of ventricular depolarization, so from Q to S or from R to S, depending on whether you have a Q or an R or not, that width is greater than 0.11 and direction is to the left, but takes a lot of time, that's probably a left bundle branch block. If current is to the right and takes a lot of time, that's probably a right bundle branch block. Now, these are very simplistic ways of looking at our patient's EKG when we're evaluating unstable tachycardia. But if we just look at what's normal in V1, normally away from the positive electrode on the right side of the heart and towards the positive electrode on the left side of the heart, this is normal. With a right bundle branch block, you have a primary end direction towards the right heart. And that gives you an upright in lead 1 and V1 and a deep S wave in V6. And with left bundle branch block, the direction is normal, but look how much time it takes to depolarize the ventricle. Now remember, bundle branch block occurs when your conducting pathways in the bundles actually are just too slow in repolarization to accept a new initiative, such as when you have junctional tachycardia, when you have AV nodal reentry, when you have atrial fib, when you have atrial flutter, and those atrial depolarizations are being conducted very rapidly through the junction. Part of what's going to happen to your patient is they're not going to be able to conduct this normally down their bundle branches, and that's why we see a bundle branch block. So also, we just take a look at the characteristics here of the right bundle and the left bundle. Remember, primarily to the right in V1 and taking a lot of time, and that terminal return of current towards the right heart in V6, giving you that wide deep S wave. In the area where the bundle branch is blocked, you will also have an inverted T wave. So this is a right bundle branch block, current towards the right, abnormal, taking a lot of time, abnormal, and a T wave inverted in the lead that's looking at the bundle that's blocked. On the opposite side of the heart, that would be V6. I have a normal left-sided depolarization, but then a return to the right, signified by that wide deep S wave, but your T wave is upright. With a left bundle branch block, we see that the current is going away from the right, which is normal, but it's taking a lot of time. And then when we go over to that left-sided lead, V6, we see that current is coming to the left, but it's taking a lot of time, and the T wave is inverted. So these are really important when we're evaluating wide QRS tachycardias. So in our previous discussions, again, doesn't matter whether you were here or not, we talked a lot about SVT, and to remind us that protection of the AV junction and also bundle capability may well be that there is an inability to conduct this rapid formation. So if we have SVT, we know that depolarization initially, the control of the heart is arising from above the ventricle, but we don't really know where, can't see a P wave, can't really identify, is it junctional, is it atrial, is it something else? We don't know if it's reentry. We don't know anything except that we believe, because the rhythm is irregular, we believe that it's supraventricular. This is SVT with a left bundle branch block. And you can see here in V1, you have a primary downwards and it's taking a lot of time. And in V6, you have a primary upwards and it's taking a lot of time, and your T wave is inverted. Now, this is not the greatest example, but you can also see that it would be easy for you to look at this and say, I think this is VTAC. Now, really, it doesn't matter if it's SVT with left bundle or VTAC. If your patient is unstable, you're always going to cardiovert. But here's the problem. Problem is, if I have a V1 or a lead 1 on my cardioverter defibrillator, the synchronization may be seen as needing to occur right here, because the monitor might read this as your ventricular depolarization. And of course, it's not, it's your T wave. So you would never use a lead that had a primary downwards deflection with a thin, narrow, upright T wave, because you could sync in the wrong place. So you would always want to choose a lead that might not look as good to you, but that your monitor is going to be able to identify more significantly for synchronizing the delivery of the electrical joules. Okay. This is an AV reentry tachycardia, and we just want to remind ourselves about reentry tachycardia. Very commonly, reentry tachycardia goes along an accessory pathway. That accessory pathway is a connection between the atria and the ventricle without delay. Our AV junction delays depolarization, but these accessory pathways, they just communicate rapidly. They can communicate in a forward direction or in a backwards direction between the atria and the ventricle. And what you're seeing here, this would look very much to me like a left bundle branch block, right? Primarily downwards in V1 and upright in V6. In either case, let's just remember that if the patient is unstable, we're going to cardiovert, and we want to choose a lead where it's really clear when ventricular depolarization is. Not so clear with this lead, going to be very clear here, but you need to cardiovert. You don't want to defibrillate this patient because you can then cause an RNT, and now the patient can go into VTAC. Here's another, this is a re-entry from the fascicles of the bundle. And again, this looks very much like a left bundle branch block. So look at these patterns here. They all look like a left bundle branch block, okay? And they all appear that way. So again, what we are going to say here is you have a wide QRS tachycardia. Your rate is very rapid. It appears to be in a left bundle branch block pattern, and there is some mild to moderate irregularity. So remember, with supraventricular dysrhythmias, they tend to be much faster than VT, and they also tend to have some irregularity. Here, we're looking at ventricular tachycardia coming from a focus that's in the RV. Now, for me, I'd be a little bit hard-pressed to say that this was VTAC because, by the way, it looks very similar to all these left bundle branch block patterns. The current is going away from the right heart because it originated in the right heart, but now it's pointing to the left. And it looks very much like a left bundle branch block pattern. Now, this is ventricular tachycardia from the right ventricle. In either case, because I'm uncertain in any one of these, I just want to mention, I am going to want to cardiovert, and I want to be sure that I choose a lead where the monitor can clearly see the R wave and not confuse it with the T wave. Here, there's lots of confusion with the T wave. Here, it's very clear what the R wave is. So you need to be sure that the lead you are monitoring and that you're synchronizing to has a clear R wave and that there's no confusion with the T wave, okay? So just remember, all of this is showing you current is going away from the right and towards the left. That means that it's all relatively downwards in your right-sided lead V1 and all relatively upwards in your left-sided lead V6. That makes you think a left bundle branch block pattern. It could also be VTAC, but again, if the patient's unstable, we will cardiovert. Now, this is just a regular EKG, just to bring that forward to us to say, we're looking at our patient, we're seeing that it's downwards in V1, downwards in V2, downwards in V3, ultimately is upright in V5 and V6, but wide, meaning that the current is going to the left heart, but it's taking a lot of time. The T wave is inverted in V6, and you can see that depolarization in the right-sided leads, V1, 2, and 3. And in the left side leads, normally V4 would be upright. Here it's not because it's a left bundle branch block. But in V5 and V6, you see that it's upright and wide. I'm going to confirm that by looking at the other left-sided leads. So left-sided leads are 1, AVL, V5, V6, and I see it's all upright and broad, taking lots of time with an inverted T wave. This is a left bundle branch block. Oh, the blocks, oh, the blocks, the blocks, the blocks. Don't forget, in left bundle branch block, the impulse transmits rapidly to the right. That little tiny right ventricle depolarizes quickly, and now the current goes all the way over to the left. Impulse goes to part of the apex and the base of the left ventricle, and all of that is delayed. That's why it takes more time. It's a slow impulse causing a longer depolarization time, that wide time greater than 0.12, but the direction is still to the left, which is the normal directional current when we're talking about a left bundle branch block. Okay. So again, just taking a look at V1 versus V6. Remember, V1 is primarily downwards, T wave is upright. V6, the QRS is primarily upwards, but the T wave is in the opposite direction. So that's a really important perspective. The other is right bundle branch block. Now, right bundle branch block is a lot more common when we're talking about patients with supraventricular tachydysrhythmias with a wide QRS pattern, because the right bundle repolarizes slowly. So frequently when you have patients who have a heart rate of greater than 130 or 140, they are going to conduct in a right bundle branch block pattern. And what's so important about that right bundle branch block pattern is that when you're looking at a right-sided lead, what you're going to see is the majority of current is coming towards the right. That is never, never normal. Okay, that is never normal. Current should always go to the left, So if current is coming to the right, you're going to see it inscribed as an upright in your V1, and it's a big upright, and the width of time is going to take longer than 0.12 seconds. So now we're going to take a quick look at SVT with a right bundle branch block pattern, and this is really can be difficult for us, okay? So what you're seeing is current to the left, and then return to the right with an inverted T wave. And in V6, what we're seeing is this broad, deep S wave here. Okay, now if I was only looking at V1 and I saw that, I might say, oh my God, it's VTAC, okay? But when I'm looking at V1 and V6, which is one of the reasons it's so helpful to have a 12-lead EKG with a rhythm strip, looking at V1 and V6, I can say, oh, this is a right bundle branch block pattern. And I can see that both in V1, current going to the right, and in V6, current going away from the left to the right, which inscribe that deep S wave here. Now, again, if that patient is unstable, all I want to be sure that I'm doing is choosing a lead, and that's going to be pretty easy here. Choose a lead where it is easy for my monitor to identify ventricular depolarization. So I can choose V1 or V6 here. I could probably choose lead 2 as well to synchronize and cardiovert my patient. Here, you have VTAC that's coming from the left ventricle. So current is leaving the left side and going to the right heart because it arises in the left ventricle and then travels to the right heart. So you look at that and you say, Barbara, that looks just like a right bundle branch block pattern. And you know what it does until I look over here at V6. Okay. And in V6, with right bundle branch block, I still see current coming to the left heart. Here, I only see current going away from the left heart. So all current going away from the left and towards the right, that helps me to identify VTAC from the left ventricle. And again, what I want to reiterate to you, I want to reiterate that to you, is if the patient is unstable, the most important thing I have to do is assure that I find a lead where my defibrillator can actually identify where the QRS is and separate that from the T wave. So really, really important to remember that sometimes this astute diagnosis is impossible in a situation of unstable environment. So not to worry about that. Think about cardioversion. Think about the application of cardioversion, and just be sure that whatever information you're giving to your monitor, I'm so sorry, is effective. So again, when we're looking at VTAC arising from the LV, all current goes away from the left, unlike right bundle branch block where you still have current that goes to the left heart, all current goes towards the right. This is VTAC from the left ventricle. So just in case you didn't have enough bundle branch block, just take a look at this picture. This is a beautifully identified right bundle branch block, current going to the right, giving me that upright in my right-sided lead. Never normal to have a big upright in my right-sided lead, but now I've got a big upright in my right-sided lead with an inverted T wave. And when I look down at V6, what I see is current goes to the left because my left ventricle is still healthy and okay. And then current returns to the right, and that gives me that broad S wave. This is a right bundle branch block. Okay, so now let's take a look at this. Okay, so what do we think this actually is? This is actually atrial fibrillation with a left bundle branch block evaluation. That same patient who actually got treated, now take a look at your patient. So look at him again here with this irregular wide complex tachycardia. When you first looked at it, I can almost guarantee you said, that's VTAC, okay? The patient's got a pulse. His blood pressure has dropped a bit, might be diaphoretic, but he's not in shock. And first and foremost, you see this is irregular, okay? Whenever it's irregular, you're always going to second guess that this might not be VTAC. And again, remember, if the patient's unstable, you're just going to cardiovert, going to try to find a lead that's appropriate for cardioversion. But as we look more at this patient, we actually see that the patient had atrial fibrillation and what we call a re-entry tachycardia. So he just kept re-entering in a circle the activation. That's why his heart rate was so rapid. And now you can just see here, it's a little bit hard to see, but you can see here in V2, you've got some fib waves, which are really, really, really important. Okay, I think probably this is Raphael Warnick or Stacey Abrams, but not them personally, just their people calling me. I've already decided who to vote for. Don't worry, you can't convert me now. Okay, so one of the things that we think about is that with AV reentry tachycardia, so really, really important, especially for providers who are on the phone, I know we have a few, is really, really important to remember if I believe that this is a reentry tachycardia, and I typically won't know that when I see the rapid rhythm, but if I treat that patient with reentry tachycardia with something like adenosine, they actually will not respond to adenosine. These folks typically, because the reentry, so what that means is they have a pathway that connects the atria to the ventricle. That pathway tends to be sodium channel responsive. So of course you'd have to have a cardiologist on board, but you're going to give sodium channel antagonists like Pronestal or Ibutylide. But remember, if the patient's unstable, you'll always do cardioversion. Oh yeah, this is Elmer Fudd wrote this, cardioversion. No, cardioversion is what you're going to do for those patients. Just in case you don't know who Elmer Fudd is, Elmer Fudd had always had trouble with W's, so that's why I said that. Okay, so here we are. Now we're looking at this patient. This really brings to my focus, right? Whenever you have tachycardia with hemodynamic instability, first and foremost, you want to ensure it's not sinus tachycardia. Something I remind everybody today, I'm teaching boot camp. I remind you that you're trying to make some good decisions about what's happening for your patient. Go into the room on your bedside monitor, press the EKG waveform, toggle down to change speed and change to a 50 sweep speed. That will spread the waveforms out and will allow you to look at whether or not you have the presence of a P wave. So if you do have a presence of a P wave, you're going to consider this might be sinus tachycardia. You never want to cardiovert that patient, right? But if it's not sinus tachycardia and your patient has a very rapid rhythm, you can cardiovert them with or without sedation. Always sync. And always be prepared that after you deliver a synchronized cardioversion, you should be prepared for bradycardia. So that means you've got adrenaline and epinephrine on hand. You should be prepared for hypotension. Maybe you already have a bag of norepinephrine or you've got fluids. You should also be prepared that you may have some left ventricular dysfunction. Also be prepared that you may have to initiate CPR. And that's post-sync. Now you can see right here, the shock was delivered on the T wave, and you now have gone into what we would call here, torsade du point. And that, of course, is our biggest worry about shocking on the unstable time of the ventricle, and that would be the T wave. So what happens when DC shock is delivered on the T wave, not on the R wave, delivered on the T wave, R on T phenomena, and that's what happened right here, not on the R wave, on the T wave. I'm sorry, that's my handwriting. So, okay, so we deliver that shock during that period of time. This patient now has completely lost consciousness and the patient is in V-fib. And of course, the doc is going to say to the nurse, what did you do? Now, let's just take a look at this beautiful visual. And this really brings to the point what I wanted to mention to you here. So this is a 50-year-old man who has palpitations, found to have regular wide complex tachycardia. It's pretty regular. We're not really certain whether it's VTAC or SVT with wide QRS tachycardia. Although when I look at his V1 through his V6, what I'm going to tell you is this is all negative concordance, meaning all the R waves are pointing in the same direction. So I'm going to have a tendency, because it's quite regular, I'm going to have a tendency to think that it's VTAC, but I'm still going to cardiovert him. But when we hook him up to the monitor is saying, this is your R wave. And so synchronization shock is delivered, assumably on the R wave, but it actually was delivered on the T wave. And now the patient has gone into torsade du point or ventricular fibrillation. So by the way, just because you turned on your synchronization button, your job isn't over. Make sure that the monitor is able to identify the R wave as separate from the T wave. Here, where you're seeing the synchronization that has told you when it's going to deliver a shock, that's occurring on the T wave, not on the R wave. And this patient went into a polymorphic V-fib, or what we would normally call torsade du point. Now that's really important because torsade du point is going to be treated differently than VFib or VTAC, and we really need to know that. We need to be prepared for that because sometimes we do shock on the T wave. We deliver an R on T and cause patients to go in TDP. Okay, so that kind of takes care of the SVT and the bundle branch blocks. And now let's just think a little bit about VTAC and VFib, things that you're very familiar with. I don't think you have much trouble diagnosing. Always remember VTAC means your impulse is originating in the ventricles and you're depolarizing in a completely abnormal way. It's going to take a lot of time and you've completely lost your atrial contraction kick. So whatever the atria can deliver into the ventricle has been totally messed with. So always remember, take your own pulse, try to be calm, try to organize yourself to understand ventricular tachydysrhythmias. Lots of different ventricular tachydysrhythmias. The three I want to talk about that are completely contained in the ventricle: monomorphic, one focus; polymorphic, multiple foci; and torsade du point, also known as TDP. And I'm going to refer to it from now on as TDP, torsade du point. Okay, so sorry. With monomorphic VT, what's really important to remember is that tends to be quite regular. It's one focus manipulating the ventricles, and really, really important. Now, if the duration of the tachycardia is greater than 30 seconds, you're going to need intervention. And you're going to need intervention for that sustained tachycardia. And depending on whether or not the patient's hemodynamically unstable, will determine what your intervention is going to be. Okay, we certainly know that we have lots of non-sustained VTAC. That's 3 or more beats that just terminate spontaneously less than 30 seconds. We're going to watch that patient. They might be stable, they might be unstable, and it has very similar and common features for any broad complex tachycardia. So we're always going to be aware of that. We're going to remind ourselves that a regular wide complex tachycardia is most likely VT. This is your ACLS guidelines, 12 lead EKG. Consider expert consultation if you have time. Use amiodarone 150 IV over 10 minutes. That's from the new ACLS guidelines. And or perform elective cardioversion. Okay, now you're going to use amiodarone if things get worse with amiodarone, or if you're giving amiodarone to somebody with TDP, they may get significantly worse. So it is really important to try to, as quickly as possible, actually try to assure some diagnostic significance. How do you do that? Okay, well, first of all, suggestive of VT wider than 0.16 seconds or 160 milliseconds. Doesn't look like right bundle or left bundle branch block. So remember, if I have right bundle branch block, current goes to the right, and the terminal current on the left side also goes to the right, giving me an S wave. That's a right bundle branch block. Left bundle branch block, all current goes to the left, and it's wider than normal with the inverted T wave in the left-sided lead. Now, I'm doing this very quickly. I've spent lots of times on bundle branch block. I've done 1 or 2 hours on left bundle, 1 or 2 hours on right bundle. And I'm not assuming that everybody attended that, but our purpose here is to say, when you think you have VT, it does not look like right bundle or left bundle branch block pattern. It has a very broad width, greater than 160. It's absolutely regular. And if you were to look at your axis, and we're just going to do that very basically, looking at lead 1 and AVF, if it's downwards in 1 and downwards in F, that's going to be an extreme axis. An extreme axis almost always points to VT. So very, very, very important for us when we're thinking about that significance. There are particular signs known as the Brugada sign that talk about positive or negative concordance. That means that you're pointing in one direction. That in your V1 through V6, the R wave points in one direction, either downwards or upwards, either called positive or negative concordance. And of course, you're dissociated completely from the atria, so you may have P waves, but they are not correlated in any way, shape, or form. Okay, so again, this patient looks like here in V1 that could be a right bundle branch block, but here in V6 or V5 doesn't look like a right bundle branch block. What this is a left-sided ventricular tachycardia. It's absolutely regular. Current goes away from the left and towards the right. When I first look at V1, I say, oh, it's a right bundle branch block. But when I look at V6, I need to expect that I've got some upright, and I don't have any upright. Only my T wave is upright. Now, remember, if this patient's unstable, because I'm not always certain, I may not have time to really diagnose appropriately. I'm thinking a lot about what's happening for my patient. And I'm going to say, okay, he's a bit unstable. I'm going to cardiovert him. And I'm not going to choose leads that have these big T waves, right? I'm going to choose a lead like this lead, V2, where it's really clear where the R wave is, and so that my monitor can synchronize appropriately with the patient. Really important when I'm thinking about this overall of how I'm going to treat the patient. Do I think amiodarone might be beneficial for this patient? Absolutely. Amiodarone, remember, is a potassium channel antagonist. It works both on supraventricular and ventricular disorders. So a lovely agent for me to use. Okay. Frequently, when you're at the bedside, if you have a cardiologist who is on board with you and wants to know what else is going on, they might say, you know, pretty much I can tell you from looking at this 12-lead EKG, you have only one focus. So this is a monomorphic VTAC, one focus only, and that means that every single complex looks just like the other. All of these things look just like the other, except here where you kind of had a little normal beat. All the rest of these beats look just like the other. So I don't really have a question that this patient has VTAC monomorphic, meaning one site. Again, I look at V1, I say, oh, that looks like a right bundle branch block. And Miss Barbara told me about right bundle branch block, T waves inverted, current going to the right. But I also have to have a big upright in V6 and not such a big downward. Because I don't have much upright in V6 and a really big downward, really not much delay. This is a left-sided ventricular tachycardia, single focus. Now, your cardiologist will often say, when they see that you have some different looking waveforms, cardiology will say to you, please do a long rhythm strip. And here we have a rhythm strip, lead 2 and V5. Now, I'm not in love with that. I don't think that was a good choice. Look at how much lead 2 and V5 look alike. What I really would like to have is a lead 2 and a V1 in terms of rhythm strips, so that V1 is looking at the right side of the heart and lead 2 is looking at the left side of the heart. Can it depend that your EKG tech knows what you want when you say, I need a rhythm strip. Best choice in rhythm strips, lead 2, V1. So you can see here, lead 2, so your positive electrodes down on the lower left chest, and V5, your positive electrodes down on the lower left chest. They look almost exactly the same. That doesn't give me the kind of information I need. I need to look at the heart from two different sides. So I'm going to ask my EKG tech, who does it with a simple flip of a button, can you give me lead 2 and V1, right side and left sided leads, so I can have a better view about what's occurring in my patient's heart. Okay, and again here, what you're going to see is wide QRS tachycardia, upright in V1, downwards in V6, most likely, even though the EKG can't really tell you. What you actually have here is a left-sided ventricular tachycardia. Now, this is a person with just a pacemaker. And the reason I want to put the pacemaker on here is I want to remind you that when you have, this is an AV sequential. So here's your atrial spike and your ventricular spike. But whenever you're using ventricular pacemakers, you're always going to have a wide QRS. You're typically going to have T-wave inversion. That's going to be in a lot of different leads that you see that visualization when you have ventricular pacing. So I'm going to remind you to consider these fine cues. QRS morphology, similar to previously seen PVCs, which are really important for you to pay attention to, is going to suggest VTAC. If all the complexes from V1 to V6 are pointing in the same direction, either upright or downwards, that's called concordance. So positive concordance means all pointing upright. Negative concordance means pointing downwards. No concordance means they're not pointing in the same direction. But if you have concordance by Brugada's sign, concordance means all the complexes point in the same direction. VTAC is likely. Okay, almost all negative QRS in V6, almost all the time, the primary downwards in V6 suggests VTAC. Okay, especially wide QRS complex greater than 0.16 suggests VTAC. Well, how fabulous is that? Because in VTAC, remember, I'm still going to consider cardioversion, but I'm also going to anticipate that that's going to degrade. into ventricular fibrillation. So I'm going to be prepared for that, right? Wide QRS tachycardia, not so much, unless I do RNT phenomena with cardioversion. But with VTAC, I'm going to be prepared for degradation into VFib and, of course, requirement for CPR. Okay, so taking a look at this, you can see you're upright in V1, downwards in V6. Okay, so this is not all pointing in the same direction, and this is actually a right bundle branch block. Okay, so that's an SVT with the right bundle branch block, but something else you could rule out would be left ventricular VTAC, but this is actually SVT with the right bundle branch block. Taking a look at this, you can see V1, 2, and 3, 4, 5, and 6, all pointing in the same direction, all pointing upwards. This is called positive concordance. This is VTAC. Okay, take a look at this. Okay, V1 is upright, V6 is upright with the downward. This is a right bundle branch block. So a lot of information to talk about here. Okay, so now I'm going to end today with my discussion of torsade de pointe. I have a lot to say about torsade de pointe, so hopefully I'm going to get that done in the next few minutes. Torsade de pointe is also known as polymorphic VTAC. Polymorphic VTAC means you have more than one focus and you have basically reentry or a circle reentry of electrical depolarization in the ventricle. The thing that makes a torsade de pointe, rather than calling it polymorphic VTAC, is that I saw the origination of the dysrhythmia and I saw an R on T. Torsade de pointe is uniquely related to R on T and is frequently caused when you have long QT syndrome. Long QT syndrome means that your QT corrected is outside of normal limits and you either fire on your own sinus node, fires an impulse, and that lands during the unstable downside of the T wave, putting you into torsade de pointe. So we're going to take a look at a couple of visuals of torsade. One of the things that's really important about torsade, and it's not always this obvious, is that it's like a crepe paper streamer that you're twisting and hanging. It's wide, narrow, wide, narrow, wide, narrow. But it doesn't always look this formal and this exact. Very, very, very important. Differentiation of polymorphic VT versus TDP. Because in TDP, you have long QT syndrome, and that's going to be your focus to shorten that QT syndrome. With polymorphic VTAC, you have multiple ectopic focus in the ventricle. You're going to treat these very differently, okay? Very different treatment for TDP from polymorphic VT. And if you're treating it incorrectly, you can make the patient much worse, okay? So basically, you have to know that you had a long QT and a long QT corrected, really. So greater than 480 milliseconds corrected is going to be considered abnormal. A little different between men and women, but let's just say 480. Anything greater than 520, you need to be on the phone with your provider talking about the QT, thinking about what medications can be taken out of the patient's armamentarium in order to try to shorten that QT. You have basically what you have is if it looks like TDP, but you had a normal QT and it was not RNT, it's going to be called polymorphic VT, and I'm going to treat that like VTAC. But if you have a long QT and you have an RNT phenomenon in TDP, you're going to treat that very, very differently. Okay, so let's take a look at this patient. You can see that your patient fired on R on T, and you're looking at a 1280 kg. So let's look down here at the rhythm strip, and you can see fired R on T, kind of has a long QT syndrome here, fired R on T, and now you got the twisting of the points that we're going to call torsade de pointe. Okay. Polymorphic VT, very, very important, tends to have short runs of about 15 seconds, and the rate is typically 200 to 240 beats per minute in polymorphic VT. In TDP, I'm always going to suspect that when I see that I have a patient with a long QT syndrome. So by the way, today in cardiac boot camp, I just remind everybody that on your bedside monitors, you can always look at QT corrected. You should never, ever have a cardiac patient or any patient on Haldol or Haldol's babies, right? Or any patient on amiodarone or any patient in targeted temperature management without displaying QTC on your bedside monitor. I think that's malpractice and negligence. So I'm just letting you know seriously that when we think about these patients who actually can have congenital long QT or iatrogenic, we gave it to them in the hospital, a long QT with our medication, or who have severe electrolyte imbalances, and now they have QT prolongation. You have the capability to monitor QT corrected on your bedside monitor. It needs to be there. You need to pay attention to it, not just because you want to click and say you saw it, but because as the QT prolongs, your patient's at risk for torsade de pointe. Now, your patient gets torsade de pointe, that's going to be pretty unstable. It generates into VF, but treating torsade de pointe will be very different than treating polymorphic VT. So first and foremost, very simply, I'm going to just say, on your bedside monitor, that may not be the most reliable QT measure, but you're looking at the trend. What I want to just remind you is that if your QT is greater than half of your R to R interval, that's the short form way to look at it. QT from the beginning of the QRS to the end of the T wave is more than half of your R to R interval. You have a prolonged QT. You got to know what medications cause this. You got to understand why your patient's at high risk, and you have to be advocating at all times. Monitor QT corrected with patients on high-risk medications, patients who have significant risk factors, patients who are on TTM, patients who are getting any kind of extrapyramidal control like Haldol, Risperidol, any of the babies of Haldol, patients on Zofran, patients on gentamicin. You need to know. You can't memorize all of them. You're not a pharmacist, but you need to know that, quite honestly, everybody who's on a monitor should be getting QT corrected, and not just to add another piece of monitoring, but to give you something of value that's going to allow you to care for your patient. Okay, so always, if you have concern and you have time, have someone else look at the EKG. Ask a cardiologist to measure the QT corrected interval. And always remember, if your patient has long QT syndrome, they need a cardiac consult. So it's great to have expert medical folks. It's great to have expert CVICU folks. It's great to have expert trauma surgery folks. Great to have expert ER folks. But if you have long QT syndrome, if your QT is longer than 480 and really greater than 520 on your patient, you need a cardiologist to look at the patient, because that cardiologist, and in particular the electrophysiologist, is going to help you a lot in terms of determining what's going to occur for the patient. Our very first patient who received TTM here at Grady was a 16-year-old girl. She fell outside of protocol, but Greg Martin and I determined that she really should get TTM. She had a cardiac arrest because she had congenital long QT syndrome. She wasn't on any medications. She had long QT. She fired RNT. She went into torsade de pointe, then deteriorated into VF. She responded to electrical shock. She had return of spontaneous circulation, but she was neurologically unavailable when she arrived here at Grady. So we put her in TTM. She was our first patient. She woke up after we warmed her. She woke up. She graduated from college last year. So it is really important because, by the way, she had 3 younger siblings. She was 16. She had 3 younger siblings. She and one of her siblings actually received an implantable pacemaker cardioverter defibrillator because 2 of the children out of the 4 had congenital long QT syndrome. So it does happen. It's not uncommon to see it. Now, again, remember what torsade looks like. It typically, remember, it has to occur during a prolonged QT interval. That's either congenital or acquired in the hospital. And that RNT phenomena, which puts you into this twisting of the points, usually short-lived, oftentimes will resolve itself, but if it prolongs, it will progress to VFib. Okay, so very wide complex tachycardia, more than one focus, sinusoidal, flipping the points, no discernible P waves. And here again, you're going to see this is called VTAC by your monitor, but this is actually a torsade de pointe. Okay, we're going to look at a lot of them. because they really do change. So this is a patient who actually had a long baseline QTC, who then had an RNT phenomena and polymorphic VT, but because she had a long baseline QTC, we're not going to call it polymorphic, even though it is polymorphic. But because of the long QT, we're going to call it torsade de pointe. And then that disappears into ventricular fibrillation. Okay. Again, taking a look at this patient, has an RNT phenomena right here, goes into a torsade de pointe. It's very hard to see everything because it was outside of the scale of our recording strip. And again, another beautiful example of torsade de pointe. Look down here at your rhythm strip and you can see how those points are twisting. Now, this doesn't look like some of the other torsade de pointe that we looked at in a lead 2, but if I switch it over to V2, it would look much more like what we've looked at before, much more obvious that it's TDP. Okay. So here's a patient who's on amiodarone, who has a QT corrected of 747. Now, remember, I told you greater than 520 is concerning. This patient has a prolonged QT from amiodarone of 747, fires an RNT and goes into torsade de pointe. Amiodarone, in its antidysrhythmic property, prolongs your QT. Now, because it prolongs your QT, it makes your ventricle refractory to depolarization. But because it prolongs the QT, it also puts patients at risk for RNT phenomena. This is another patient on amiodarone who goes into torsade de pointe. Okay, so if it's torsade de pointe, I want to remind you, the drug of choice is not amiodarone. It is magnesium sulfate. So for VTAC, you're going to give amiodarone. For torsade de pointe, you're going to give magnesium. You're going to give 1 to 2 grams IV and then follow with more magnesium over 60 minutes period of time. Now, in the end, you may end up giving amiodarone, but that is not your first choice. So we had a cardiac surgical patient in bed 10 in the CVICU was before Dr. Ward was here, who went into torsade de pointe. The first thing that was given to that patient was amiodarone. Patient deteriorated into VF, not the right drug to give torsade de pointe. Remember, if I'm a provider, I'm only going to know that the patient probably has torsade because you were actually monitoring the QT. You were documenting it, you were discussing it. You're not just pointing, clicking, and checking. This is incredibly important because it tells me about patients who are at risk. If I'm the provider and I believe it's torsade de pointe, I don't want to do amiodarone. I'm going to give max sulfate. I may try defibrillation. Defibrillation torsade does not always work and oftentimes causes deterioration. So max sulfate is going to be the best thing that I can give. Okay, so just be ready. TDP is given 3 basic therapies: magnesium, defibrillation, and temporary pacing after the route of TDP is resolved. Okay, why are you going to pace? Because you need to increase the heart rate to shorten that QT interval. And then, of course, that patient is going to need to be evaluated. Try to avoid amiodarone. Amiodarone prolongs the QT. Defibrillation may work. Magnesium should always happen first, regardless of the MAC level, and then look at the potassium and if you need to correct it. As soon as TDP is resolved, if you think the patient's at risk or they've had 2 or more episodes of TDP, you're going to start temporary pacing. You then may consider that they're going to go to the EP lab and they're going to get a permanent pacemaker with cardioverter defibrillator. What you want to do is remember that bradycardia, so if a patient vasovagals, they're pushing down to have a bowel movement, they already have a long QT, and now the heart rate slows, the QT prolongs even more, and now they go into TDP. So one of the best things you can do is protect them from bradycardia. So we're not going to do that with atropine or epinephrine. We're only going to really do that with pacing. So defibrillation, magnesium, pacing. And try to avoid amiodarone if at all possible, since amiodarone prolongs the QT. So remember, when we're looking at tachycardias, we're determining that they're fast. Our next goal is to say, are they narrow or broad? Are they irregular or regular? And that's how we're really going to make decisions. Think about what it is we're going to do to treat our patients, how we're going to treat our patients, and what those components are. If you have wide QRS tachycardia and it's stable, I'm going to consider adenosine, but only if the heart rate is absolutely regular. If the patient has AV dissociation, meaning that the atrium and the ventricles are not connected, but I have a stable wide QRS tachycardia, I'm going to use amiodarone. And if there's no response to either one of these, I'm going to consider cardioversion. If the patient's unstable, I'm always going to do cardioversion, DC shock, and CPR. Okay. If your patient has accessory pathways, and you really wouldn't know that if you didn't really know the patient really hadn't looked at his EKG. But if he has accessory pathways, most commonly being Wolff, Parkinson, White, you cannot give these patients adenosine, calcium channel blockers, or beta blockers because they will get much worse. So by the way, I'm the provider. I haven't seen the patient. I'm responding to your call for help. I come in the room. I have no idea that whether or not the patient has WPW. All I see is a supraventricular tachycardia. Patient's relatively unstable at a very rapid rate, and I say give adenosine. If I give adenosine 6 and then 12, and the patient doesn't get better or they get worse, I now have a diagnosis. This is an accessory pathway. Adenosine, calcium channel block, and beta block should not be given to the patient. So I'm not telling you everybody is going to diagnose that you have an accessory pathway. They're not going to. How we're going to find out is when we treat the patient and they get worse or they don't get any better. And if they don't get any better and you gave 6, 12, 12, cardiologists will sometimes give more adenosine. But why? It didn't work when I gave 6, 12, and 12. Let's not do it. Let's move on to the next step. And of course, the best step, always, 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 cardioversion. It's always. Okay, so when we look at wide complex tachycardia, we got to differentiate VTAC from SVT with aberrant conduction due to bundle branch block. We need to differentiate from SVT with aberrant conduction due to accessory pathways like Wolff, Parkinson, White syndrome, because we're going to treat all 3 of these very differently. We also have to differentiate from pacemaker mediated tachycardia. That's going to be a little bit easier. Got a pacemaker. We're going to look at metabolic derangements like hyperkalemia and differentiate wide complex tachycardia from that, and also from poisoning with sodium channel blocking agents like tricyclic antidepressants. All of these will present with wide complex tachycardia. It's inherent on us to know the patient's physical history and their relationship, and to always try to do the right thing. Okay, so remember, when you have hyperkalemia in your serum and you're severely acidotic, hyperkalemia in the serum is usually hypokalemia in the cell, and this patient is going to progress very quickly. You can see how wide his QRS is, how high his T-wave is. His T-wave is as high as his QRS, and he's really giving you some good information. If you look down here at V2 and V3, you see how sharply peaked the T-waves are and also how narrow they are, which is very common with hyperkalemia. Okay, and this is what happened to him. His pH was 6.8, his K was 9.0, and here is how he progresses, and he does it really, 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 really fast. And you can see that you have concordance here. Everybody, all the QRSs in your chest sleeves are pointing in the same direction. But this is from hyperkalemia. So ACLS, meds, ACLS guides will not treat a patient who has toxicity or metabolic abnormalities. This patient really needed to mobilize this potassium from his serum into his cell, and that was done, of course, with 2 amps of bicarb and 2 grams of calcium chloride. So look at what happened when that was administered. Beautiful. Got the patient under control. Really beautiful. Okay. So my take-home message to end the 3-part series of unstable tachycardia. Remember, pulseless versus with pulse, stable versus unstable, narrow versus wide, regular versus irregular, underlying reversible cause. And in general, what you want to do is control the rate and or the foci and refer that patient to cardiology. So the last patient that we're going to look at is this one, which has nothing to do with unstable tachycardia, but such a beautiful patient. Patient, 50-year-old, was brought in by EMS with a complaint from the family that she fell and she was shaking. And so we're doing an EKG, and all of a sudden she has a second episodic change in a level of consciousness during the EKG. So whenever that happens, of course, you want to get a 12-lead EKG, you want to get a pacemaker nearby, and you want to remind yourself that seizures can be caused by dysrhythmia. And of course, your patient has a complete heart block at that point. All right, my friends, thank you so very much for joining today in Wonderful Wednesday. I hope I'm going to see you next week for more fun in topics in critical care.